there, I'm Dr. Thomas Martin from the University of California in San Francisco, and we're here today with Blood Cancers Today, discussing bispecifics and how we incorporate these new novel therapeutics in our treatment armamentarium for relapsed multiple myeloma. And I'm joined with several esteemed colleagues.
Hi, I'm Angela Dispenzieri, Mayo Clinic, Rochester, Minnesota.
Hi, Ajay Chari, recently at University of California, San Francisco as well.
Ajay Nooka from Emory University.
Ajay, you had mentioned, that there are other options in the space. So now we're looking at post-fourth line therapy, right? So what, when you think about CAR T-cell therapy and bispecific, how do you choose between the two?
That's a tough one. I mean, it's this whole new world that we're entering in terms of, okay, what is really going to be the best sequencing, and again, where in the lines? I mean, okay, we have fourth line, but is it going to come sooner? And then the other struggle is, it's hard sometimes to get to fourth line because a lot of people are being treated with quads up front, and then and maybe transplant, and so then and they're maintained on one therapy, and then sort of getting to fourth line is really interesting and challenging. But as far as sequence, to me, I am imagining, but I don't have data to back me up. Probably CAR Ts are going to be earlier and maybe replacing transplant as they are in lymphoma to some extent. And then later on, perhaps the bispecific, because again, as mentioned, CAR T, you need to prepare, and relapse is not predictable. And so it'll be interesting. But again, will bispecifics be some type of maintenance? I mean, there's so many questions to answer. And will they be in combination, something to enhance T-cell performance,
Yeah, that's going to be fun, actually, learning about all that and actually kind of finding what is going to be the best sequence or the best combination. So in your practice, Ajay, for now, if you see a patient and you talk to them about CAR versus BiTE, what do they usually choose?
I think the fact currently we should mention that all of these products, both bispecifics and CAR Ts, are approved for 4 or more lines of therapy in triple class exposed. So if you stick to that label, which currently we have to, thanks to the payers, then I think, to me, the single best therapy in myeloma to date has been cilta-cel, right? With the response rate approaching 100% and the PFS of almost 3 years. It's hard for anybody to beat that. And not only those efficacy, but the treatment-free interval, which translates into tremendous quality of life benefit for patients. So I would say if that's my goal, if I can get a relapsed refractory patient who meets the indication to cilta-cel, meaning they don't have explosive disease, there's a reasonable chance of getting a slot, then I would try to prioritize that and not do anything to jeopardize that. And I think that's important because we do have some preliminary data that CARTITUDE-2, when you give prior BCMA-directed therapy, that PFS plummets to less than 6 months for bispecific. So I would not do TEC or ELRA in somebody who I'm taking to cilta-cel. Whether GPRC-directed therapy affects it in the same way, I don't think we completely know yet. I think part of the issue is when do you collect the T cells, right? Yeah. Because I think if you're going to do cilta-cel, I think collect first before you do any bispecific, including GPRC, because one of the limitations of bispecifics, I would say, as a group, is we don't really know a lot about the long-term dosing and schedule. I think we're glad that we have accelerated approval for all of these, but I know that, in myeloma, we're so busy getting things to our patients, then we also have to kind of catch up a little bit and be like, wait, how are these working? What's the right long-term strategy? So I think for now, if I have a patient who I can get to cilta-cel, I would probably collect T cells first before exposing them to even tau, and then do the cilta-cel. And if they've already had cilta-cel, then I think what we're also learning, there was a really cool paper in Nature Medicine that just came out about losses of expression, right? And that 16p is where BCMA sits, 12p is where GPRC sits, and we're understanding that there's more mutations and losses of both of these targets. So those are going to be very important, along with T cell function, to sequence thoughtfully and not just like do the kitchen, let's just throw everything together. And then the last point I would say is if you do have prior T cell redirection, this may be where we either need a gap in therapies or combination strategies to overcome some of those issues.
So Ajay, so Angela brings up a good point that CAR T cells, it requires a whole commitment by the patient, a caregiver, coming to the center, et cetera. And Ajay said it's, these bispecifics are off the shelf. So give me a real world picture of Emory. So how many patients really go to CAR versus those that go to bispecifics at the current time? What do you think? What would you estimate that would be?
Absolutely. I think this is a very important discussion in the clinic that happens. So the first thing that I lay out with the patients is these are not mutually exclusive treatments. So if you get one, that doesn't mean that you should not get the other one. So which makes it easier for the patient to make a decision, oh, I'm not losing one option by choosing the other one. So now the next question comes in here is like, what is the optimal treatment strategy to move on? And in myeloma, we've seen time and again, the most effective treatment is the one that we first go for. And I go with probably what Ajay said before, going on with the CAR T with the most effective treatment strategy. But when the patient is progressing, so that's where it becomes the biggest question, what is the next optimal solution? So going back to the question that you asked about the bispecifics versus CAR T, if I lay down to the patients, and if there's a patient that is rapidly progressing, I probably don't give an option in terms of, hey, you should choose a CAR T first because of the availability of the off-the-shelf agent. Like me and the patient can decide and the patient can get it next week. And similar to what your experience is, we had treated probably 51 patients as we speak with the bispecifics over the last 7 months. So we never treated so many patients in such short time frame without knowing what the long-term efficacies would be. But these are great times, and I always encourage the patients to go with the most optimal effective treatment that they have at that specific time that the disease would be amenable to respond to.
Yeah, I completely agree. And I would say that I have an individual discussion with every patient, lay it out, a month in San Francisco versus coming back once a week or once every other week in San Francisco for the drive. And it's really, in my mind, it's a different decision for each patient. One patient said, oh, I want the 1 month and I'd be done with it and then I get the free period for sure. And the other patients say, oh, I'd rather just come in once a week, drive in, get my therapy, or once every other week and then go home. So it's actually the patients decide too. Sometimes, like you say, the disease makes the decision for us, right? Sometimes that happens.